Hello, everyone. Good evening. My name is Eileen Frank. I am the Chief Curator at the Connecticut Historical Society, and thank you for joining us this evening. Last year, the Connecticut Historical Society opened an exhibition called Common Struggle, Individual Experience, an exhibition about mental health presented by Hartford Healthcare, which is on view for about 2 more months at the Connecticut Historical Society. The exhibition explores how society has sought and continues to seek care for the mind and mental health. Today, we mark a new and important development in how Connecticut cares for the mental health of our youngest citizens. New legislation signed this spring invests $300 million in expanding mental health services for children. Tonight, we've assembled a panel of healthcare providers from Hartford Healthcare and Connecticut Children's to help families and educators better understand what this new legislation means for them. I thank Howard Savronsky, who is on tonight's call, who is the Chief Behavioral Health Officer at Connecticut Children's. He served on the Exhibition Advisory Board for the exhibition Common Struggle, Individual Experience, and he really led in organizing tonight's panel. So thank you so much, Howard. I am now going to turn this conversation over to Allison Matthews-Wilson, Director of the Center for Care Coordination, who will be our moderator for tonight's event. Allison.
Thank you, Eileen. Good evening, everyone. I'm so excited to be here with all of you this evening for this really important discussion. And I'm going to get right to it because we have lots of good content and conversation to be had. So I'll start by introducing our panel. As was just mentioned, we're joined by Howard Savronsky, the Chief Behavioral Health Officer at Connecticut Children's. We're also joined by Dr. Melissa Santos, the Chief of Pediatric Psychology at Connecticut Children's, Dr. J. Craig Allen, a child and adolescent psychiatrist, as well as the Medical Director for Rushford and the Vice President of Addiction Services at Hartford Hospital. And finally, we're rounded out by Dr. Robert Keder, a developmental and behavioral pediatrician at Connecticut Children's. And important to note, all three are on faculty at the UConn School of Medicine. So excited to have the panel. Would love to get started, Howard, by taking a look at something that Eileen had just mentioned, which is really talking about what the state of Connecticut is doing in response to what our Connecticut's pediatric mental health crisis and what some of the new laws that are going to go into effect and some of those conversations at a state level. If you could kick us off in that way.
I'm going to do my best. Thank you, everyone. And thank you to the Historical Society for hosting this tonight. We hope that this is going to be a very informative and very useful panel conversation. So we all know that the pandemic that we are still reeling in focused all of our attention on the behavioral health system that was already in trouble. But responding to the outcry of families, advocates, kids, the legislative leaders in our state did something really remarkable. I'm going to just share my screen for a minute. This year, we saw something that was historic and bold. The leadership in our state legislature really listened to the people who were most affected by this pandemic and really struggling to find resources for their kids who are experiencing an increase in behavioral health issues. It was remarkable in that it was a bipartisan effort by both chambers of the state legislature. What was really incredible is that they really actively sought from government officials, providers, advocates, families with lived experience, their direct input so that the legislation truly reflected the needs of our state constituents. The legislation that they passed was wide-ranging, expansive, and had at the end of it all, the budget to support all these initiatives. But one thing we do know is that it did not fix everything, but it did set an agenda for the future of behavioral health in the state. There were 3 major bills passed. One with HB 501 was from the House, the Senate Bill number 1, an act concerning children's mental health and physical health, and a Senate Bill 2, which expanded the preschool and mental health services for younger children. While the laws, the legislation was very expansive, I just wanted to pull out and just highlight some of what I think are the priority issues that were addressed by this legislation, and I think would have the most impact on families and kids going forward. This legislation significantly enhanced school-based services for our children. A key element of both the House and the Senate bills focused on expanding clinical social workers and psychologists in our schools, expanded school-based clinics to provide better mental health care for our kids, established trauma-focused coordinators at each of our school districts to bring trauma-focused care and recognizing the impact that trauma has on children, as well as creating a peer-to-peer support program for kids in grades 6 through 12. The bill further enhanced infant and early childhood services by expanding the funds, providing funds for pediatricians to provide behavioral health care in their medical homes. It fortified the behavioral health workforce by expediting licensing for mental health providers. It provided resources for expanding psychiatric residency and fellowship programs. And it provided incentives for hospitals and organizations to hire mental health practitioners. The bills further increased inpatient bed capacity, which was a major problem facing us at the beginning of the pandemic. In addition to providing incentives for hospitals throughout the state to expand bed capacity in their facilities, it also, thankfully, to Connecticut Children's, provided us with $15 million to help support the creation of a 12-bed medical psychiatric inpatient unit that is currently in process of being developed. The bill increased mobile crisis services for adults and children. This is a key service support for families who are confronted with a crisis in their homes where they can call, and within 40 minutes, a mental health practitioner will be able to show up at their homes or at the location of the crisis and help address the situation that they're confronting. The program has now been expanded to cover 24/7, as well as the expanded geographic areas throughout the state. We may remember some time ago, there was a terrible incident in Hartford where a young boy overdosed on an opiate. And this really brought a lot of attention to the way in which we manage opioid addiction in our schools. Part of the law that was passed permits the administration of opioid antagonists to school students in our schools. And I'm sure Dr. Allen will be able to address this a little bit more later on. It fortified suicide prevention measures by establishing 988, which is a new suicide hotline that is now being available in Connecticut and actually throughout the country, which is connected to the National Suicide Hotline. So those individuals, children, families, adults who are confronted with an acute suicidal state can call 988 and get direct help. The law further mandated coverage for mental health wellness examinations, recognizing that most children who begin to experience some kind of mental health issue wind up seeing and seeking services and help from their pediatricians. This law will allow at least 2 visits to their pediatricians at no cost to receive mental health assessment. It increases the distribution of domestic violence resource information by the police and emergency medical staff who are now required to have those resource sheets on their possession when they respond to situations in the community. The bills continue to support our community-based outpatient programs by expanding certain specific programs that are designed to deliver care to kids in their homes. And it, for the first time, increases the state oversight of children's behavioral health by establishing a new mental health and behavioral health policy oversight committee, which will be chaired by the legislature, will be comprised of leaders from various sectors throughout the state, that is being charged with looking at and examining how we can best improve care to our kids in Connecticut. But what's next? So I think we all agree this is a great start, but we do need to continue to talk and plan. We're hoping that this is the beginning of a conversation that will continue in next session, which will start in January. The funds that largely were used to implement these programs were ARPA funds. These were federal dollars that were received by virtue of the pandemic. We must advocate with our state to find more sustainable ways of maintaining these programs once these ARPA funds end within 2 years. We want to encourage all of you to really push our government officials, our providers, our legislator, to really promote innovation and best practice development so we can bring the best quality care to our kids and families. And most importantly, to all of those who are listening, we encourage all of you to really reach out and have your voices heard. The legislature, the providers, the policymakers need to hear from families, from children with lived experience who can tell us exactly what is being felt and experienced on the ground so that we can better improve the care going forward. So I encourage all of you to go, as we enter into our new school year and our new legislative session, to really become actively involved in trying to help shape a better and more improved system of care. Thank you.
Thank you, Howard. So I think what I'd love to do next is Howard's really set us up with the 30,000-foot view of what's going on in the state. And I'd really like to get down into a little bit more of the ground level. And so for a lot of parents and caregivers that might be listening to this live or as a recording, we've come to hear about a pediatric mental health crisis from pretty overwhelming headlines and news stories talking about how much our children are struggling. And the news coverage often focuses on crowded emergency rooms and really frightening statistics. What I'd love to do is ask the panelists to join in by sharing with us, how are you seeing the mental and behavioral health crisis play out in real time? What are you seeing in your work day to day? And I can either open it up or I can choose if somebody wants to get started. How about Dr. Santos? You want to take a stab at this?
Sure. So I think perhaps what the pandemic has highlighted is that there's no part of our workday that the mental health pandemic isn't being seen. And I think, we spend so much talking about, we really need to treat the whole child. And I think that's the maybe good that's come out of the pandemic. If we could talk about any good that's come out of this increased attention of mental health, is that it can no longer be separate from the child. Like you go to that clinic down the hallway or things like that. We really have to talk about the whole health of the child. And to do that, you have to talk about, are you taking your vitamins? Are you brushing your teeth? Are you eating green, leafy vegetables? How's your mood temperature kind of going on? And so I think that we're seeing it in our kids that are coming in for medical care and for everything like that, but we're also seeing it more in our providers taking that mental health approach of really the whole child and that their emotional health, and having conversations that perhaps they were hesitant to have in the past because they weren't sure or they were afraid to stumble over their words. So long way of saying it's every day, it's everywhere, both in the patients and also the way our providers are treating kids now.
Thank you, Dr. Santos. Dr. Allen, what about you in your day-to-day work?
Well, the increased, we had a problem as Howard mentioned earlier with access and awareness of services for children and adolescent mental health services before the pandemic. And then pandemic increased the stress and decreased the moods of parents and caregivers and kids. Those things are associated with other problems, poor school performance and behavioral problems, but also substance use. And the more anxious, the more depressed someone is, the greater the risk that they might try to alleviate that by using substances. And so I've certainly, we've seen at Rushford and I think in the entire state, an increase of kids and young adults who have turned to using substances and are now trying to function with two different issues that require coordinated treatment. And as Dr. Santos said, you have to treat the whole kid. You can't just treat depression and leave the vaping or the cannabis use or the alcohol use to run wild, because the depression is not going to get any better. And treating both of those disorders might not be tapping into what is underlying some of the problems that drove someone to get so involved in using those substances. So on the upside, I'm seeing an awareness that we really need to create an environment for our children that is rich and engaging and exciting, and an alternative to using substances, and also one that won't be so likely to stress kids out. And we need to provide those supports and put them in place in the schools, in the communities, and certainly in the healthcare facilities.
Thank you. Both of you talked about those earlier signs: stress, anxiety, depression, which are words that we hear a lot about. Dr. Keder, I wonder if, as a developmental behavioral pediatrician, could you give us some basics? Could we start with some common language, and you share maybe for our audience some of those signs that family members and caregivers might start to see, and that would elicit the idea, and maybe I need to talk to somebody about this. What should we be looking for?
Sure. So I think that there have been a couple of things. The pandemics, plural, or syndemics, however you want to kind of define them, have really presented that there's a whole lot of things that kids have been dealing with, and we're just putting more stress on the whole system, which is even harder for kids. A couple of things to help clarify. You might hear some different terms. Some people use mental health, some use emotional health, some use behavioral health. To me, as a scientist, it's all the same thing. It's all mind-body integration. And as a developmentalist, that means that I'm not just focused on where a child's motor milestones are and when they walk or when they talk, but things like emotional self-regulation is really important. And we're paying more attention now to social and emotional development as a result of everything that's going on. Now, when we think about it as a system, we've been sometimes waiting, and we kind of identify things when it's hit a point where it's like, wow, this is really a problem. And what we need to do is keep doing a better job of screening and watching for kids, because these behavioral and emotional and mental health issues don't just pop up overnight. They creep in, they're very slow. We know that some kids are more at risk than others. The joke is you can start to sense what we call temperament, or it's kind of like the mini personality, even in a baby. And the joke is, once you have a second child, you're like, oh, baby number 2 is so different than baby number 1. I thought all babies were the same. They're not. And if we pay attention to which kids are wired a little differently, we know that there are some kids who are more sensitive. And that comes as a trade-off, right? That's the child who, if you help them learn how to get ahead of that, they can pick up in a room of 100 people who's having a bad day. But they're also the child who, if left unchecked or isn't taught how to help kind of deal with that, the child who's going to fall apart or cry because things are hard. And then they might start to develop these, what we call maladaptive coping skills. They might turn to things that are different and not as healthy for them. I know one of the things that we talk about with young children, like one of the hardest things you can do is take a crying child and just pull out a phone or screen time, because it's an opportunity that we're missing to help that child learn how to emotionally self-regulate without giving them this high input, high busy stimulus that hits some of the same parts of the brain as other substances that kids could use when they get older. And we see that kind of like addiction circuit. So like whenever I work with parents and they're like, Why is it that they have a meltdown every time I take the tablet or phone away? I'll say, imagine that you've had a really long day and you've had a really nice beverage in your hand right now, and halfway through it, I just smack it out of your hand. And everybody gets this like emotional feeling and reaction. And that's what your kid's going through when you just like take it away from them. So we have to think about what we're doing, but thinking developmentally means we're thinking not just now, we're thinking about the future. And with how parents are framing this, there was one parent who said this years ago, and it's like one of the best parent quotes I've ever had in clinic. They said, we live in a world and a society where you go to a dentist every 6 months to get your teeth cleaned and checked. Shouldn't we live in a world where every few months you go to get your brain and feelings and emotions checked? And I was like, run for office and put that on a bumper sticker because you have my vote. But it's taken us a complex pandemic to help start getting there. So I really do think that this is an opportunity to not just think of emotional and behavioral health needs like when they get to that problem point, like 9 out of 10 problem. We need to start thinking about how we help shape kids and support kids through therapy if needed, but also public health ways. Like, what's the benefit of social emotional learning, where we can help kids develop a vocabulary to talk about feelings. And then the other thing is stigma. And what the pandemic has really shown is how much stigma can be a barrier. So how do we kind of put on our anti-stigma, or another term, anti-ableist perspectives, where we can really help people acknowledge that emotions and behaviors are a part of everyday human life. And it's better to help work with them to be healthy and not be embarrassed about it, because we're all human.
So Dr. Keder, just to play off something you said with that brilliant quote from one of your patients' family members, the reality is our healthcare system isn't set up to have our brain sort of looked at every few months. So what would you say as a practitioner, how can parents sort of monitor some of those maladaptive behaviors, some of those changing affects in their kids, and work with their healthcare provider to ensure that, in that short well child or sick visit, that they're getting all that information and sharing in a way that the practitioner is able to sort of track and support the family best?
So thanks. That's a good question. And I think that there are a couple areas that we need to kind of shift how we're thinking. Yes, whenever you go visit your primary care person, there should always be what we call screening and surveillance, meaning that we're checking in, talking about, and thinking about these things. It's always helpful for me as a physician when a parent comes into clinic with a list of questions or things that they're worried about, because that helps us have an agenda to kind of guide what's going to be helpful or meaningful to the family. What's also important, though, is checking in. Like, right, your primary care and medical providers are only part of your child's life. And we see a child not terribly often compared to, say, like a teacher or a social worker or even a coach. So check in with the people and adults who are part of your child's life. See how things are going. When you get older kids, they're not the child that has to tell you everything that's going on in their life, but it is your job to make sure that they have someone that they can talk to, an aunt, an uncle, a brother, a sister, someone. So we want to think about, are our kids connected and supported? And the most basic part of that is making sure that they have an adult or someone who's older that they can feel connected to and secure with. Other things to think about: talk about stuff, normalize talking about feelings at home, right? I don't know about all of you, but sometimes it feels like as a generation, we grew up and we weren't allowed to have feelings as a child. And that wasn't necessarily a helpful thing, right? As a whole generation of people. Instead, the issue isn't that kids have emotions, it's that emotions are a natural part of the human condition. So what we really need to do is normalize how we talk about it and role model how we deal with it. In this way, it's okay to say, like, honey, mommy or daddy is in their red zone right now, so we're going to take a 5-minute cool down because I don't want to say something I don't mean, right? And then we're acknowledging that we have emotions and feelings, right? We can acknowledge, like, honey, I'm feeling really nervous about you going to this place, right? How can we help talk about addressing my nervousness with that, right? And then it's offering your preteen or a teen an opportunity to say, like, well, hey, mom, here's going to be this adult here and this there. And then you're normalizing talking about anxiety and you're helping build those communication skills. So we want to normalize it and make sure that we're inviting kids to talk about it without fear of being punished or stigmatized.
I think what's great about some of that you've just shared, Dr. Keder, is also that it's putting parents who are probably pretty overwhelmed and watching their kids for all sorts of things, everything from bumps and bruises to, new school fears, social anxiety, changing bodies, all of that. It puts in, using your practitioner and the folks around you to recognize that you are your child's best advocate and you know them best. So seeing signs and things that are changing, it's important to sort of, as you said, track that and then bring it to your providers and talk with people about what you're seeing. I want to shift gears just slightly. Dr. Santos, one of the things that we know is that at some point a recommendation might be made to say that all that really healthy self-talk that you're having with your child about your emotions and their emotions, that may not be enough. You may need help. And when we want to teach parents how to ask for help, and some of that is that your child may be referred to see a therapist. I guess I'm wondering if you could talk a little bit, there's so much out there, it almost can become overwhelming, right? Analysis paralysis. And I'm wondering if you could talk a little bit about how do I choose? There are community-based clinicians, there are private practice clinicians, there are programs in my child's school, in a hospital clinic setting. How do I even start looking at that and making the best choice for my family?
It's a great question. And actually, before I answer that, is it okay if I piggyback on Dr. Keder's response for a quick minute?
Right.
Because thank you. Because I think one of the things that I would want parents just to remember too is that when we talk about the emotional health of a child, it doesn't always come out in emotions, and that sometimes what we may see for kids a lot more tummy aches and headaches. And so just to kind of also be mindful of tracking those physical symptoms that may come out a little bit, because some kids can't emote in a way that is going to be what you think about a kid with anxiety or a kid with depression, but they may have crippling tummy aches or crippling headaches or things like that. So just to kind of monitor that. And I'll actually invite Dr. Keder to help me with this response too, because I think this is something we talk about a lot, is whether or not it's important where or the what of what the provider sort of does. And I think it's really important. The mental health system is not set up for success in any kind of way. It's hard to navigate. It's hard to navigate as a mental health clinician to figure out, like, how do I even get, like, who do I call to even help you with this? And I think the key part sometimes is even to figure out what is it that your child needs. A younger child is going to need something very different than a teenager is going to need, than someone that needs to see Dr. Allen for substance abuse or things like that. And so oftentimes I think the focus has to be on what the needs are. Is it a family kind of service that's needed? Is it something that the child needs it? Is it a parenting? Because for younger kids, it's really going to be focused on the parenting aspect. And I think it's more important that we're clear and that families are clear on what the what is, maybe a little bit more before the who. I hope that makes sense. I know, Dr. Keder, this is something you and I have talked about a lot in the past. So I don't know if you want to add on to that.
Sure. So just kind of like when we talk about if you have, say, pneumonia, we would give you a medication like an antibiotic, but we use different antibiotics for different reasons. In the same way, there are different types of therapies, different types of therapists. And as Dr. Santos said, it can be really confusing to navigate, but you want to make sure that you're identifying what the problem is and then using what we call evidence-based practice or what research shows is really effective for that, and trying to connect with that type of service if you can. So if you have a child who's older and very verbal and they can talk and they're feeling sad or anxious or depressed, something like cognitive behavioral therapy or CBT is great, but you have to identify what's the issue going on. On the other hand, if you have a child who's experienced trauma or could have PTSD, then we want to make sure we want to connect a child with trauma-focused therapies that really understand how kids who've been through trauma might act out or have, challenging behaviors that seem funny and weird until you understand how trauma works. And then all of a sudden it helps the child and the parent and the family really go, oh, okay, I get this now. This isn't about this, it's about that. And as Dr. Santos said earlier too, really trying to uncover stuff because things might look like one thing, but could be another. I work with 4 and 5-year-olds who are anxious, but that might look like tantrums and meltdowns, right? What does a panic attack look like in a young child? It could just be that I'm falling apart. So we want to identify that. We also want to think about too, helping empower families to use therapy, because therapy is meant to be, like all things, learning new skills. So when I talk with parents, especially with young children, I say, think about therapy like learning how to play the piano. If you wanted to do that, you'd get a piano therapist or a piano teacher. But if you have a 5 or 6 or 8-year-old who only touches the piano once a week for a half hour, are they ever really going to make a lot of progress in that? And parents go, no. But then we ask, who are the kids that do learn how to play piano? And they're the ones whose parents either sat through the piano lesson with them, or they know how to help encourage the child to practice a little bit of piano every day. So therapy shouldn't be just passive. It should be something that the family is actively engaged in. If you have an older child, it's okay for the therapist to not tell you everything, but you can check in for a minute or two and just ask, how can you be supportive for your child, right? And that's the main thing. We want to encourage growth, and we also want to pay attention to making sure that we don't double punish a child. When we talk about disability, right, we have what I call visible disabilities and less visible disabilities. If we saw a child in a wheelchair, we would never say, get up and walk. Oh, fine, you didn't get up and walk, you're grounded. But when we work with kids or even other adults or friends with behavioral and emotional health problems, there's a lot of times where we're in situations asking them to get up out of their wheelchair, so to speak. And what we have to do is make sure that we're not double punishing a child for the actual struggle that they're dealing with. So that's where a little bit of what we call psychoeducation is really important for parents too, to help understand why your child does the behavior that they do, because then that gives us a little bit of insight and an awful lot of patience to figure out how to keep helping them through it without punishing them.
And I think just to add on to that, I think it's also important for parents to understand that the work of therapy may not always be done forever. And I think it's one of the tasks of a mental health clinician to understand that we may be ending our work today, but you may need to come back in a few months or in a few years or see somebody else. And that's okay. You know, just like you might see a knee specialist this year, everything's good. And then you got to go back for like a tune-up every now and again. So I think that that's also an important part to understand, is that this is part of just overall health. And there may be times along the way that your child needs tweaking. And that's where the mental health clinician can kind of come in as well.
And I might not even say tweaking, but coaching, right? Because we're all lifelong learners, and really continuing to normalize this, right? We're all getting coaching in our academic or professional lives to a degree. But what about coaching for that emotional health and well-being, right? You might get a personal trainer to help coach you in physical fitness. And in the same way, it's okay to consult or check in, or, you know, even have that once in a while, because then that's really making sure that you're working towards wellness. And that's the real goal.
One of the things I just want to follow up before I move on to the next question is, you know, the advice we're hearing is that, you know, participating in social emotional learning and therapy should be just part of our life as we're growing and going through experiences. And I think that the COVID pandemic has given us a lot of options, right? We would never have been on a Zoom call 3 years ago. And so there's some pros and cons to that. I wonder if folks could talk a little bit about when parents are offered telehealth, you know, virtual therapy visits, and may have some concerns about what that means. It certainly fits into a calendar a little bit easier, but are you really getting the same quality of interaction that you would have if you're sitting in front of a therapist? And I wonder if folks have, I'm guessing it's not a one size fits all, but I wonder if you could speak to that. Dr. Santos, I know you do both. Do you want to do that?
I think it's very kid specific, and I think parents know your kids the best. I think at the height of the pandemic, kids hated telehealth. I don't know that kids are fans of telehealth even now, but I think that, you know, when you sit in front of like I've been in front of Zoom since 8 o'clock this morning, it's tiring. Like I've been staring at myself for 9 hours now, right? And I think that the same with kids. It's effective. Telehealth is effective. It works. It's sometimes easier for families to fit it into their schedule. But for some kids, this may not be the best avenue. But for some kids, it may be a nice first step to feeling comfortable to coming into the office. I think about our kids with really profound social anxiety, sometimes working on those steps, thinking about our kids that have chronic pain, that sometimes getting up and out of the house is just really hard. So I think that it can be a nice segue as well. So it doesn't have to be an all or nothing sort of thing, but I really think it does vary. And then the other hard part is that we know for some families, telehealth is not an option. You know, telehealth is a great thing, if you have Wi-Fi, if you have smart technology, if it's reliable. And I remember in the pandemic doing telehealth sessions with families in parking lots in public areas that perhaps I would not normally do therapy because it was the only place they could get Wi-Fi. So it is, I think, very family dependent, and I think it's very kid dependent, but I do think it has a use. And I think for some kids, it may give us an avenue into helping them, particularly those kids that might be really hesitant to take the first step to coming in person. I know, Dr. Allen, you had unmuted as well.
I love your explanation. I was going to say something along those same lines. It really depends on the family and the kid. And certainly, I was trained in the old archaic fashion of meeting with someone three-dimensionally and meeting the kid and meeting their family. And we used to have phones and talk to people on the phones. Now we have these smartphones and Zoom calls. But what I found are the tremendous opportunities, and the flexibility and the convenience is really hard to beat, particularly for really busy families. And I love your explanation of, someone who has social anxiety. I hadn't thought about it that way before. What a great way to engage them before you meet them. It's funny, I think back when I was up in Boston many years ago working with kids who had some difficulty communicating, some developmental disabilities. And I used to use a screen to engage them while they were sitting next to me. And we would play a game on the screen, and I would talk to them, and we would play games and so forth. So I guess there's a use, for the screen. And I certainly, we do both at Rushford, and I do both myself. So it's really maybe half a dozen of this and 6 of the other when it comes to, and it's really nice to have another tool. It's like, I'll think of it that way, tool in the toolbox.
I'm going to keep you going, Dr. Allen. One of the things, so now you've found your perfect match, and you're working the therapy. It's part of your everyday care for self. And so you've sort of checked that box. And now a recommendation comes down the pike for medication management. And that can be really overwhelming, and people have lots of different opinions on it and comfort levels. I guess my question is, what would you say that parents need to know when medication is recommended? What questions should they be asking their providers?
Yeah, I think the most important things are along these lines. What are we hoping to get out of this? And I often ask the patient, ask the kid, say, what are we hoping this is going to accomplish, this medication? Now, I have some idea because I've recommended the medication, but I want to make sure we're on the same page. So what are the target symptoms? And how long before we might see some improvement? And what might that improvement look like? And is there a way we are going to be able to track that? So sometimes there are easy ways to track, like if some kid has attention deficit disorder, you can use different surveys or scales with teachers and with parents, and even in the office. Other times it's a little more challenging, but I think it's really important to identify the target symptom and the time until you're going to see the benefit. A lot of medications that we use in child and adolescent psychiatry don't work like Ritalin, and it takes a couple of weeks for them to start to see, or hopefully see, the positive benefits. Another area that's really important is, what might the side effects be? What should I look for? And which ones are really, really important? I've got to stop the medication, call the doctor, or what should I do? Maybe you don't stop the medication, but you do call the doctor. And what are the kinds of things? Well, we see that frequently. It should go away. It's a little bit of a stomach ache. That happens for the first day or so sometimes. And, just give me a call, or we can talk about it next time. So that's really important. Another area that's really important is potential interactions with other medications. And when you're treating, well, you treat any age, but adolescents, older kids, are there interactions with things that kids might get into or be using if they get a cannabis, a gummy or something, or if they're smoking marijuana or drinking alcohol, using other types of drugs. It's important to know what the potential side effects there may be. And I think, and I know I'm going to miss something, so Rob will jump in, or Melissa, but the last one that's on the table for me is, if well, okay, there's two more. One is, if you miss a dose, what do you do? If you miss a couple of doses, what do you do? Because it can be different. And there's some medications you don't just go ahead and give it at night because you might keep the kid up all night. There's other medications where it's okay to just go ahead. Do I double up on the dose? I mean, those are the kinds of things you want to know as a parent. You don't want to be just doing that because you have a feeling about it. And then the last point that I'll make is, when do we stop it? When do we stop it? Either because it's been effective and can we have a trial off of it? Or when do we stop it because it's ineffective? And obviously, if there'd been side effects and so forth, it may have been stopped earlier. So it's effective, it's been working, it's been 3 months now. Can we stop the medication? That's a conversation you have to have because it's different with different diagnoses and different medications. And then look, it's not working. And do we stop it? And unfortunately, from time to time, I see kids who are on medications or multiple medications, and it's not clear that any of them have worked. And so it's important to keep that in mind. Rob, Melissa, you got some things to add there?
I mean, I did love how really, I think it is important that if a child does take any kind of medication, we define what the target purpose of it is, right? Just like you would have a goal for therapy, you have a goal for medications too. And we need to do it and figure out a good way to track it, because sometimes life gets busy and it's hard to go based off of like, I feel good or not, right? We do want to be mindful. And a lot of this requires mindfulness because there's just so many other competing things going on. We also want to pay attention to understanding that certain things get treated differently. We think of stuff like ADHD, attention deficit hyperactivity disorder, as not just something that comes and goes like anxiety or depression. ADHD is a lifelong condition. And part of the goal is helping a child learn how to self-accommodate their own differences. And this is where we celebrate something called neurodiversity or neurodivergence. But part of the goal with any child is, as they get older, that we're giving them the tools and toolkit to be independent in managing their own needs. So at some point, that child who you're trying to get to swallow a pill to take their ADHD medication when they're 6 is going to be 18 and maybe going off to college. And we need to have that discussion about, how would you take the medication? How do you decide if you need to do work on a Saturday or if you want to take a holiday off on a Saturday? How do we help you make sure you're getting in charge of that? Just like if you're working with a child with anxiety, how do we help them recognize that sometimes when life feels good, it's because we don't have any stressors on our plate? So how do we make sure that we're staying ahead of our anxiety and working with it and really trusting ourselves and checking in to help manage it? So it's about all of these becoming tools, and we want to invite the child to utilize them. And we want to pay attention and destigmatize this, because I talk with parents a lot. If I said, your child has asthma, here's your child's inhaler, everybody goes, oh yeah, sure, sure. Your child has an infection, here's their antibiotic. Yeah, sure, sure. Your child has cancer, here's chemotherapy. Yeah, yeah, sure, sure. Your child has ADHD or anxiety or depression, here's medication. And everybody's like, no, right? And that no is stigma speaking, because the whole point is we're not here to sedate children. We're not here to change who a child is. We're here to help promote that child being well. How do we help them get to living to be the fun, happy, independent child that is going to be that fun, happy, productive, independent adult that they want to be, and still discover who they are in that whole process? So, our goal is not to change who kids are. It's about really helping enhancing kids to reach the best of their potential. And that's what all these are. They're tools to help kids do that.
Thank you. That was great. Let's talk a little bit about, fall is definitely in the air. I noticed when I wake up in the morning, it's a little bit cooler. My kids are back in school. And so, with fall, we start to think about school, and school is a huge part when we think about pediatrics. It's a huge part of their kids' lives. What can we expect from schools? What role do they play in, you got your therapist, you have your relationship with your coaches and your pediatricians, and we talked about making sure we're checking in with folks that know our kids best. Some of the people that know our kids best are the ones that are housed in schools. Can we talk a little bit about what role schools should be playing in taking care of our kids' mental health, looking out for our kids' mental health. What can we expect? What should we expect? And what role they play. I'll leave it up to whoever wants to hop on this one.
I can start. I think schools are in a really tough spot because they are where kids spend the majority of their day. They are with them all the time, and they have oodles of things that they have to do to teach and educate. And I feel oftentimes terrible, and I would love if there's an educator on this in the audience to speak up about what their experience is like. But I feel like they're oftentimes put in a situation of having to be the educator, the disciplinarian, the counselor, the this, the that, and it's a lot to expect of them. And I think that there's more that we could do with schools to help support, particularly our health systems like our own, and various other organizations to partner with schools, because none of us, I think if there's anything that we take away from the pandemic is that there is no one solution to this whole thing. And it's only when we all work together to really develop a care model for kids that we are ever going to be successful to really treat the whole child. And so we can't expect schools to do it all alone. We can't expect our hospitals to do it all alone. And I really think if there's a way, and I think there's probably better ways than what we're doing now to partner to help support schools, either through education, through screening, through providing outlets, because I oftentimes feel schools are put in situations where they are asked to do so much, they don't have enough resources, and they're oftentimes feel like they have to put kids in ambulances to send to the hospital because they just don't know what they could have done, but didn't have the resources for beforehand or anything like that.
Thank you. I'm trying to get through as many questions as I can because I see that the time is already creeping up, and we want to make sure we have a little bit of time in case folks in the audience have a question. So I'm going to jump to this one. We talk about in childhood, especially adolescence, it's all about figuring out who we are, right? And when a child feels different, whether that's real or imagined, they look different, they think different. I loved Dr. Santos said they're wired different, or perhaps it was Dr. Keder. I think that one of the things that's helpful is to understand how feeling different, whether that's in school, within our families or society, can lead to an exacerbation of maybe what's already part of maybe and what sadly has become a normal childhood experience, sort of feeling overwhelmed and all the pressures that we put on kids. So I want to talk a little bit about how children who identify maybe as different, and we can define that any way you like. We can talk about our kids who identify as LGBTQ. We can talk about the children who maybe are in different racial and ethnic groups, but living in a community where maybe they are seen as different or other. And then we certainly can talk, and Dr. Keder, you've mentioned this, kids who have intellectual or developmental neurodiversity. Let's talk a little bit about mental health and its impact on kids who already are feeling those differences. I'm open to having anyone kick it off, or I see Dr. Keder's grin. This is, I know personally that for Dr. Santos and Dr. Keder, this is a huge issue. I'd invite all three of you to chime in.
Sure. By being people, we're human creatures, we're social creatures, and we know that anything that might give you a slight different identity puts you at sticking out, literally and figuratively. As somebody who's worked a lot in the area around bullying, right? Bullying happens more to kids who are perceived as different, or who even perceive themselves as different. That difference might pose a risk of more of what we call cognitive load, like kids just feel it and they worry about that because, right, as teens, we all want to fit in. As young kids, we all want to be cool and liked, right? Even 5-year-olds can have social anxiety about school in their first day and worrying about, are they going to make friends? So we want to support those kids by helping make sure that they do have access to connections. We do want to help and start normalizing early on that, right, everybody is different, and this myth of being like the perfect human being is a myth, because everybody's got something going on. And most importantly, we want to help highlight kids for their strengths and really use that to promote their self-esteem and their identity by connecting with other kids and adults. But we do want to pay attention to our kids, and if you know that your child does have risks, keep an ear out. Ask them questions. Don't badger them about it, because if they're like, oh, mom, I don't want to talk about that, dad, leave me alone, right? That's fine. But the fact that you're offering that space to check in and you're giving them safe space to talk about it is really important.
So last year, over half of transgender youth attempted suicide or seriously considered attempting suicide. And we know that we can cut that rate in half by using the correct pronouns to refer to them. So I think it's oftentimes the impact of small things of acceptance that can go a long way. And that's the stat that always like sticks out to me about the lengths that acceptance and kindness can do for a child, is simply by using the correct pronoun with a child, you slash the rate of suicide by half.
This is, I always think of this family that I worked with a number of years ago, and the child was in, I think it was 3rd grade and entering into a new school, and he had obsessive compulsive disorder and Tourette's, and his Tourette's had a vocal component to it, and so he would have involuntary muscle movements, these tics, and he had vocalizations, so noises. The parents were very involved, and they came in and met with me and talked about what I didn't do anything. They told me what they wanted to do. And that what they wanted to do was to have the child in front of the class and present what's going on and what the problems are and take questions from the kids. And I thought that was revolutionary and frightening. And I said, well, I'm not sure that, you want to do that right away. And so first the kid worked on he did this picture book. He drew it up, and that's what he was going to show all of the kids in school. And I had a little control over it, but I thought that was a pretty good idea. And the teacher was on board. So the teachers were involved, the school was involved, the parents were involved, and he went up for show and tell. And he used his book and told them what it was like to have Tourette's. And the kids raised their hands and they asked him questions, and it worked. And he had people to sit with in the lunchroom, people engaged with him, they'd ask him questions, and you're taking away some of that mystery, not allowing the stigma to develop, or the discrimination. Was really, really helpful for him. I always think about him, and I think about parents, and I think about schools, and ways you can try to address the issues head on and answer a lot of questions for a lot of people.
That's great. Oh, sorry,
So-
Dr. Keder, go ahead.
Taking what everyone's saying, this is all about helping understand differences in disabilities. There's actually a lot of great social emotional learning curricula out there. There's one actually called Understanding Our Differences, that's based in the Boston area, and it does just that. It helps introduce kids to individuals, classmates, adults with different disabilities, and normalize it, right? It creates an understanding. And in that same way, right, when we use the right pronoun for someone, we're not double punishing them for their disability. And that's why it's really important that we pay attention to what are these differences, so that we can help a child succeed past them without kind of, holding them to the ground for it. Because if you ask your child with ADHD at 8 p.m. to clean their room, and we know that their Ritalin's not on board, that's a big ask. That's a really big ask compared to like a Saturday morning where they took their medication and it's there to help them get organized. So this is where having conversations with your child's primary care person, your child's therapist or clinician, asking teachers or your school counselors how to work through this, because it really does take a village in this sense. And the more that we can help kids understand and help themselves understand why the things that they do happen, will help kind of make that a little bit easier.
I think we have time for one more question, and it luckily comes from the audience. And it's perfect timing because we're talking about stigma and how to support. And so one of our audience members asks, stigma has been brought up a few times, and there may be parents who feel shame in getting their children help. What might you say or suggest to parents that might help them cope with those feelings? I think that's a great question to sort of wrap our evening. So you know all the different ways to ask for help, but if you're still having feelings about that, how can you as a parent or caretaker address those feelings of stigma and shame?
So your own feelings of shame around
Yes.
that. I really like the way that Rob addressed it earlier, in thinking about mental health issues, mental health problems, the same way you'd think of other physical problems. I mean, your
Mhm.
brain is part of your physiology. So I say other physical problems. And you wouldn't think twice if a kid had a very painful stomach and you thought, my gosh, maybe, he's got, there's a blockage, or maybe it's an
Mhm.
appendicitis. You wouldn't think twice if there's a very high fever. And so when your child is struggling and, and it's an emotional behavioral issue, it's helpful to know that there are interventions that are evidence-based that are just as effective as taking an inhaler for asthma and some antibiotics. So you're withholding that opportunity for your child to thrive. I mean, maybe that's a little too negative.
I think also we don't oftentimes have good support systems for parents, right? So when parents are kind of going through this is a journey they're oftentimes going through alone. And so I think sometimes even if you could find a support group or a parent organization in your local community, I think our autism community does a really nice job with this in terms of supporting parents. I don't know that, I think other ones are a little bit harder to find, but I think those sort of community organizations that are led by and for parents that are on this journey, I think are invaluable sometimes. And particularly if you can find ones that maybe match, if you have any factors that may make stigma a little bit more. So if you come from a family where that's very religious and looks, doesn't view mental illness as something real, or cultural kind of factors, if you can find something that matches that, I think it's even more successful.
Thank you. I want to be really respectful of everyone's time. It is almost 8 o'clock. We want you to take care of your mental health and take a break. I'd love to have, I believe Eileen is going to kick us, kind of close us out. But I just, I want to thank the panel. It's been so helpful to get these responses. I'm fortunate enough to work with them all pretty regularly, but it's still really nice to hear it in a succinct way, and I appreciate it. So Eileen, I'll turn it over to you.
Thank you, Allison. Thank you so much for moderating tonight's discussion. For those of you who joined us, it might seem odd that the State History Museum hosted this, but for us, it's part of the destigmatization that we've been talking about. Mental health is not something that is new just because of the pandemic, and the exhibition Common Struggle, Individual Experience really explores the history, that it is a fact of the human condition. And just as we celebrate other achievements and challenges of human existence, that's what the exhibition explores. And so we wanted to make sure that we brought people together tonight to hear about this history-making moment in the Connecticut state legislation of passing these 3 pieces of legislation, which are supporting our children's mental health. And so thank you so much for our panelists, Dr. Santos, Dr. Allen, Dr. Keder, and of course to Howard Savronsky, who has been a huge cheerleader of this exhibition and this programming. And to all of you who joined us, thank you. This recording will be made available through, I believe, our YouTube channel. And the exhibition is on view for another 2 months. We hope you get a chance to see it. And thank you. Have a good evening and take good care of yourselves.